Welcome to another video. We shall discuss fluid and electrolyte management of the surgical patient. "50 to 60% of the body weight is made of water. During an acute weight loss, for example, one goes fasting, there is a loss of salt in water, and this explains the acute or the miraculous weight loss. So the relationship between total body water and body weight basically reflects the amount of fat content. The solid viscera and muscles have higher water content than fat and bone. Therefore, the people who are lean and muscular have more water as compared to the obese individuals. So this gives you a logic why you should adjust the total body water downwards by 10 to 20% for the obese and upward 10% for the malnourished. The highest total body water content is that of infants, almost 80%, which gradually reduces down to 65% by the first year of life and then remains constant. The total body water is divided into three functional compartments. One which is completely intravascular, which is plasma. The second, which is outside the plasma but outside the cell, that is the interstitial fluid. Both of these put together are called the extracellular fluid, which constitutes 1/3 of the body weight. The remainder of the fluid is the intracellular fluid, which constitutes 2/3 of the total body weight. In the extracellular fluid, which is basically the plasma and the interstitial fluid, the major cation is sodium, whereas the major anion is chloride and bicarbonate. In the intracellular fluid inside the cell, the major cation is potassium and magnesium. Phosphates, sulfates and proteins are the cations. The sodium-potassium pump is responsible to pump sodium out of the cell and put potassium inside the cell. And this maintains the concentrations inside and outside. When this pump stops working, that's when the cell will start swelling. And cell swelling will lead to a burst of the cell. And when it bursts, there is cell death. So this is what you study primarily in pathology in the initial chapters. Now, plasma and the interstitial fluid have almost the same concentration of electrolytes, the only difference being that plasma has higher amount of proteins. This is the reason it can retain water inside its compartment. The next thing to understand is that water can freely move between compartment to compartment, whereas ionic movements is not so. Now, if you increase the volume in any one compartment, it increases the volume in other compartments also. This is because water can freely diffuse. Using the same logic, a person, when he is hyperglycemic, the glucose will start having an osmotic effect on the water. So the water inside the intravascular compartment will keep increasing, and when it does so, there is a relative reduction of sodium compared to the water level. So this explains why one will have hyponatremia when there is hyperglycemia. Using this principle that water can diffuse freely across compartments, but the ions cannot. In the previous slide, we noted that the plasma volume is 1/3 of the interstitial volume. So keeping this point in mind, the next thing to note is that sodium and water are always associated due to their osmotic and electrical properties. And since sodium and water mainly occupy the extracellular fluid, if one administers sodium and water or any sodium containing IV fluid into the plasma, it will expand the interstitial volume thrice as that much of the plasma. So logically speaking, when you transfuse sodium chloride or dextrose in normal saline, it stays in the plasma for a while, whereas after an hour, 2/3 of that volume has actually gone into the interstitial space. The next point to note is that the physiological activity of an electrolyte in a solution depends upon a couple of factors. First of all, the amount of particles per unit volume, that's the millimoles per liter. The amount of electrical charges per unit volume milliequivalents per liter, and the amount of osmotically active ions per unit, that is milliosmoles per liter. So you can't necessarily equate all these three. To get a better understanding, the concentration of electrolytes is usually expressed in terms of the chemical combining activity, which is also called equivalent. For example, sodium has a valency of 1. It has only one, it's Na plus, isn't it? It has only one cation to which it can unite. Whereas magnesium is 2 plus, so it can unite with 2. So this makes you understand that for 1 millimole of sodium, you will have 1 milliequivalent. Whereas if it's magnesium, it's 1:2 because its uniting power is 2. So this tells you the difference between millimoles, which is the amount of particles per unit volume, and milliequivalents, which is the amount of electrical charges per unit volume, which is very different from milliosmoles, which is the number of osmotically active ions per unit volume. As we just understood in the previous slide, the difference between millimoles per liter and milliequivalents per liter. Thus remember that in a solution, equalizing the molar concentration isn't enough. You need to even equalize the electrical activity on both sides. So the milliequivalents of cations and anions must be balanced. In addition to which you have milliosmoles. For example, sodium chloride. There are 2 particles there, so the osmolarity is 2, one from sodium and one from chloride. So this can change depending on the kind of salt you're talking about. Magnesium phosphate, magnesium chloride. So all of them have different equivalents, and they will be more osmotically active if they have more elements inside to react. This brings us to the plasma osmolarity, which is based on the concentration of sodium, glucose and urea by a simple formula which one can use. One should remember that the osmolarity of the compartments ICF and ECF are somewhere between 290 to 310. And this can change when there is hyperglycemia, hyper or hyponatremia, and even when there is a change in the urea levels. In this slide, we can see the water exchange which occurs in a 75 kilo gentleman. It shows the amount of water that is gained and the amount of water that is lost. So it can be gained sensibly. That means you are aware that you take the fluids. So roughly one consumes around 2.5 liters of water a day, mainly in liquids and also in solid foods. When the carbohydrates get digested and assimilated, they release CO2 and water. So this water is called the water of oxidation. The loss of water occurs in urine and sweat, and also from the intestinal route while passing stools, almost around 300 ml per day, whereas the insensible losses occur from the lungs and skin, which can increase in the summer season. For practical purposes, the disturbance of body fluids can be classified as a disturbance of volume, disturbance of concentration, and disturbance of composition. As far as the volume is concerned, if there is an increase in the volume, it is not going to be so deleterious or disastrous to the body, and it can occur either in an acute or a chronic form. An acute increase in fluids can occur during anesthesia or surgery when there's a lot of fluid transfusion taking place, which can lead to dilutional hyponatremia, especially when too much of D5 solution is being transfused. It can even occur during the renal disorders where there is a retention of salt and water. The same mechanism can occur also during trauma. Whereas the volume deficit, which is very essential, could be either acute or chronic. Acute usually has cardiovascular and CNS signs, whereas a chronic will have tissue signs. Now, most of the time the acute loss occurs during trauma or stress when there is bleeding, and this has to be dealt with immediately. it is it's worth to note that people who are fit can tolerate volume changes better than the elderly, those with cardiac problems. Because if one is suddenly transfused a hell of a lot of fluids, the elderly and those with cardiac problems can actually go into congestive heart failure, pulmonary edema. These complications are not so common with ones who are young and fit. The next point to note is that if there is an isotonic gain or loss of a salt solution, it changes only the extracellular volume, mainly in the plasma and the interstitium, having very little effects on the intracellular volume. And free water that is added to the extracellular fluid will distribute freely among all the compartments. One of the most important electrolyte which has to be dealt with in electrolyte imbalances is sodium, because sodium and water are electrically and osmotically linked. Whereas you can change the concentration of other solutes without bothering about a change in composition and concentration of the fluid spaces. For example, in hyperkalemia or hypokalemia or hypercalcemia or hypocalcemia, you don't expect much of a change in volume. Whereas you play with the sodium and the volume is now going to change. Hyponatremia can occur in three volume states. For example, the fluid volume could be high and the sodium could be relatively low. For example, if supposing somebody drinks a lot of free water. So how would you treat this? Do nothing, the body will treat itself. It can also occur during the post-operative ADH secretion. And now if the patient gets hyponatremic, one should simply restrict the amount of water that is being given to the patient and all goes well. Or if this doesn't work, start increasing the sodium concentration, as I shall explain later. Certain drugs can also cause this kind of an issue, wherein there is more amount of volume and less amount of sodium relative to the volume. Hyponatremia can occur when the volume remains the same. This occurs, for example, in hyperglycemia. There is no change in volume, but because the amount of glucose increases inside the intravascular space, as explained earlier, it has an osmotic effect in water. Thus, the intravascular volume increases, and relative to that, the sodium value drops. Similar kind of a phenomenon when the plasma lipids and proteins increase, also seen during SIADH, and the effect of diuretics. Sodium could be low when the volume is also low. That means sodium and water are lost together. This occurs very rarely during decreased sodium intake, but mainly occurs during GI losses such as diarrhea or renal losses when one gets a diuretic, and also seen in primary renal diseases. In the likely event that you need to replace sodium, this is the formula that you use: 0.6 into body weight into 144 minus sodium level. Now it looks a little puzzling, but let's make it very simple. You know that 60% of the body weight is made of water. Therefore, body weight into 0.6 is equal to 60% of the body weight, which is basically the weight of water. You also know that you have 144 milliequivalents per liter of sodium. Therefore, 144 milliequivalents per liter multiplied by the amount of liters of water in your body will give you the total amount of sodium that one has in the body. Simple stuff, huh? So if you need to calculate how much sodium you need to replace, take the patient's current sodium value. Let's assume that now it is 120 or 115. So 144 minus 115 into 0.6 into the patient's body weight. You will get a certain value which tells you that you need to replace so many milliequivalents over a period of 24 hours. Usually you don't replace that complete figure that you have, you divide it by 2 and replace that amount over 24 hours. Because if you replace sodium very rapidly, there is a danger of something called central pontine myelinolysis. Now, to make it a little easier to understand, there are certain theories about the brain cells. It says that when an osmolarity changes in the entire system, the brain cells adapt by changing certain osmolytes, for example, inositol, betaine, and glutamine. Now, if there is a rapid correction of hyponatremia, the extracellular fluid will start getting very concentrated. And to adjust to this new tonicity, the brain cells will get shrunken. And when they shrink, the shrinking is most affected in the cells of the pons. And this is what leads to central pontine myelinolysis, which ultimately leads to paralysis, dysphagia, and dysarthria. Therefore, as a rule of the thumb, correct only half that value which you got in your calculation over a period of 24 hours. 0.9 normal saline contains 154 milliequivalents per liter, and 3% normal saline consists of 513 milliequivalents per liter. So you can use these values when you need to correct the amount of sodium. There are various causes of hypernatremia. Again, it could occur with a low volume, normal volume, and a high volume. One can simply understand that there is retention of salt and water when there is a mineralocorticoid excess, hyperaldosteronism, Cushing's disease, and congenital adrenal hyperplasia. At the same time, there could even be a non-renal water loss, for example, losses from the skin and the GIT, or diuretics, which could cause a free volume loss without a loss of sodium, thus the hypernatremia. We go on to the treatment of hypernatremia in the next slide. Again, remember that while correcting the hypernatremia, one should be really slow. If you correct it too quickly, there could be problems, as we discussed earlier. The first thing to understand is that your patient who is hypernatremic will have a lesser amount of volume in the body. So you need to calculate the total body water, again by using the same kind of trick, 60% of the body weight. Remember that it changes for the elderly population. Once we calculate the total body water, we need to see the difference between the serum sodium that the patient has, his sodium concentration, and the concentration of the infusate that we shall be using. Most of the time they use 5% dextrose, so there is hardly any sodium in that. Now take the amount of sodium that the patient is having and divide it by the total body water which you calculated plus 1 liter, considering that you are transfusing 1 liter of 5% dextrose into the patient. Therefore, using an example of a 30-year-old male weighing 70 kilograms having a sodium of 165, the calculation would be 165 minus 0, because dextrose 5% has no sodium whatsoever. So 165 divided by 42 plus 1, which is 43, giving you a value of 3.83 millimoles. That means to say, if you add 1 liter of 5% dextrose, the sodium value of that individual, your patient, would drop down by 3.83 millimoles completely. Now you need to reduce sodium at the rate of less than 10 millimoles per 24 hours. Therefore, to calculate this, you say 10 divided by 3.83. So how many liters would you need to get the value down? You need 2.6 liters of 5% dextrose to do so. Remember that if the patient urinates about a liter and a half or a liter, you should add at least 1 liter for the urine loss. So that means to say you need to transfuse 3.6 liters over 24 hours. Therefore, your infusion rate would be 150 ml of 5% dextrose per hour for 24 hours, which would now reduce the sodium value of your patient from 165, getting it down by 3.83 millimoles per liter. The daily consumption of potassium is around 50 to 100 milliequivalents per day, whereas the daily excretion is around anywhere between 10 to almost 700 milliequivalents per day, depending on the renal function. But the potassium needs to be maintained at a very tight control of 3.5 to 5 milliequivalents per liter in the extracellular fluid. Because potassium has a lot of effects on the cardiac and neuromuscular activity. Hyperkalemia could increase with potassium supplementation pharmacologically, blood transfusions because blood cells have potassium as do all of the cells, endogenous destruction such as hemolysis, rhabdomyolysis, crush injuries, or GI hemorrhage. It could also happen in acidosis where there is an exchange of potassium and H plus ion, or due to rapid rise of extracellular osmolarity. If the renal function isn't so good and there is renal insufficiency or diuretics have been given, potassium values can rise then also. Hypokalemia, which is equally dangerous, can occur during excessive potassium excretion due to GI losses, especially when there is a fistula or diarrhea. It can also occur due to inadequate intake. In the next slide, we shall see the clinical consequences of hyper and hypokalemia and how they need to be corrected. During the depolarization, there is an influx of sodium and efflux of potassium from the cell. This is reversed with the action of the sodium-potassium pump. So sodium is very important for the vital regulation of normal electrical activity of the heart. And if there is a change in potassium values like hyperkalemia, it will reduce the myocardial excitability and also depress the pacemaker and the conducting tissue. Therefore, worsening of hyperkalemia will suppress the impulse generation by the SA node and also the conduction by the AV node. And slowly there will be bradycardia and conduction blocks. So the first thing to see during the hyperkalemia is weakness of the muscles, paralysis of the muscles, vomiting and nausea and diarrhea. This is the usual for most of the patients. But the ECG changes as per the thing that has been explained just now. You will see high and peaked T waves which are symmetrical. This is one of the earliest signs. Later, because of the lack of conduction or the slowing of conduction, there is a wide QRS complex and a flattened P wave and a prolonged PR interval. In the pre-terminal stages, you can also see a sine wave, and you may also have ventricular fibrillation seen in the ECG. Now, what you need to do to treat the patient is, depending on how severe or how mild is the hyperkalemia. In very mild cases, one can start on by a beta-2 agonist nebulization. You need high doses, not the usual dose. And the mechanism of action is that beta-2 agonists, they stimulate the sodium-potassium pump. Thus, they will drive potassium in the cell. An insulin dextrose drip can also be started because insulin has the habit of driving potassium inside the cell. And you give dextrose to prevent hypoglycemia. Soda bicarb can be given in the likely event of acidosis. Sorbestearate are potassium absorbing resins which can be given either orally or rectally. For severe cases of hyperkalemia which is threatening the heart function, calcium gluconate can be given because it increases the force of contractility of the heart. As you know, in potassium or hyperkalemia or potassium increase, it dampens down the conductivity of the heart and the excitability of the myocardium. For chronic hyperkalemia, dialysis is one of the best options if there is a poor renal function. Hypokalemia, alkalosis, and hypomagnesemia are usually coexistent. For every drop of 0.3 milliequivalents per liter of potassium, the pH value rises by 0.1. Because of hypokalemia, the cardiac muscle and the conducting system are increasingly excitable. Therefore, due to this hyperexcitability, re-entrant arrhythmias may be seen. The usual ECG changes are U waves, T wave flattening, ST segment depression, and arrhythmias. The treatment of hypokalemia is to replace potassium. The usual requirement of potassium is around 60 milliequivalents per day. So one should replace around 80 milliequivalents over the period of 24 hours. Most of the calcium in the body is bound in the bones, and calcium is available either in the ionized form, a protein bound form, or a phosphate bound form. As far as hyper and hypokalemia are concerned, I've dealt with them in the chapters of hyperparathyroidism for hypercalcemia, and hypocalcemia I've dealt with in the thyroid. One needs to remember that you need to adjust the total serum calcium lower by 0.8 for every 1 gram decrease in albumin. Second of all, during acidosis, there is a decreased protein binding of calcium, therefore the fraction of ionized calcium is going to increase. So keep this in mind to adjust in the conditions of hypoalbuminemia and acidosis. Magnesium and phosphorus are mainly intracellular. Therefore, anything that damages the cells like trauma, crush injuries, rhabdomyolysis can increase these values in the serum. One needs to correct when there is a low value of magnesium. In hypomagnesemia, it is necessary to give magnesium until it comes to the upper limit of normal. Because unless you correct magnesium, the calcium may not get corrected. Unless you correct magnesium, the potassium may not get corrected. So it's necessary to correct this before correcting the other electrolytes. Hypermagnesemia is rarely seen. One can see reduced level of phosphates, especially during the refeeding syndrome, because when the person is being refed, cells are being created, it pulls inside the potassium and also creates ATP bonds inside the cells, therefore the phosphorus values go down. Hyperphosphatemia again is rarely seen. These are some of the adjustments which have to be made in the likely event of electrolyte imbalance. For every rise in glucose above 100 mg per dl above normal, you should reduce the sodium by 1.6 milliequivalents per liter. Acidosis is usually associated with hyperkalemia and alkalosis with hypokalemia. The potassium decreases by 0.3 milliequivalents per liter for every 0.1 increase in pH above normal. And remember that hypokalemia and hypomagnesemia are coexistent. Therefore, correct the Mg first, the magnesium first before the potassium. As far as the serum calcium is concerned, adjust the total serum calcium down by 0.8 milligram per deciliter for every 1 gram decrease in albumin. This is because albumin is bound with calcium, and as you reduce the albumin values, the ionization of the calcium increases. There are two formulae which are used to correct or to find out the corrected calcium. The first formula is 0.8 into the patient's albumin minus 4. You should write the patient's albumin in grams per liter and add this value to the patient's calcium. And remember, the patient's calcium is in milligrams per deciliter. The second formula uses SI units, wherein the calcium is in millimoles per liter. So take the patient's calcium and add that to 0.02 or 0.025 into 40 minus the albumin. Here it is 40 because the value is in grams per liter. Again, remember that when calcium is low, you should correct the magnesium first before proceeding to correct the calcium. First, let's understand the basics of acid-base balance. Acid production takes place in the cells as a result of the metabolism of lipids, fats and carbohydrates, because in the end, when they get burnt, there is a production of CO2 and H2O. Now this CO2 combines with H2O to form carbonic acid, and then it becomes H plus ion and HCO3. The CO2 is excreted by the lungs, and this process takes place in minutes, whereas the H plus and the HCO3 are excreted by the kidneys. And adjusting the pH can take anywhere between 6 hours and takes place over days. Whenever there is a change in the pH, the acid-base buffer acts immediately to combine with either the acid or the base to prevent a change in the pH. Acid production also takes place in the cells as a result of incomplete metabolism of fats to produce acetoacetate and beta-hydroxybutyrate. Lactates are produced because of an incomplete metabolism of carbohydrates, and sulfur-containing proteins result in sulfates, whereas the phosphate-containing proteins result in phosphates. So these are the fixed acids, and CO2 is the volatile acid because it can be washed off by the lungs. So now one understands how acids are produced and how the acids can be eliminated both by the lung and the kidney. The kidney secretes the H plus ion into the lumen, whereas HCO3 is filtered and partially reabsorbed. Don't forget that the H plus combines with HCO3 to form CO2 and H2O. During alkalosis, the kidney excretes the HCO3, but during acidosis, the bicarbonate is reabsorbed and more is produced to be sent back into the circulation. Now observe these two diagrams, one on the left showing the PCT, the proximal convoluted tubule, and on the right the physiology of the distal convoluted tubule. In both of them you can see that CO2 can easily diffuse in and out of the cell, and when CO2 diffuses into the cell, it combines with water to produce carbonic acid, and later this dissociates into hydrogen ion and HCO3. In the PCT, the bicarbonate gets into the renal interstitial fluid and the H plus ion gets into the lumen. Now there are two pumps on either side, the sodium-potassium pump pumping sodium out of the cell and potassium into the cell. The sodium is also reabsorbed from the tubular lumen, and there is a sodium-potassium antiporter taking sodium in and getting hydrogen ions out. So the hydrogen ion is actively being pumped out into the lumen. It combines with bicarbonates to form CO2 and H2O. CO2 also gets into the tubular cells, and effectively water comes out, which is nothing but the hydrogen ion which is getting pumped out. So the PCT is responsible in the end for pumping out H+. Whereas in the DCT, the same mechanism holds good for the CO2 to diffuse into the cell. HCO3 and H+ are produced again. HCO3 as usual gets into the renal interstitial fluid, therefore bicarbonate on both sides gets reabsorbed. Whereas the chloride pump pumps chloride into the cell while getting HCO3 outside, and it combines with H+ to release HCl into the tubular lumen. So on both sides you can see that HCO3 goes in and H+ comes out, but the only difference being that in the DCT it is HCl that gets excreted, in the PCT it is H2O that gets excreted. So this is a rule of thumb which one can remember easily. It should also be understood that the hydrogen ion is eliminated in the body in combination with ammonium, sodium phosphate, and ammonium from glutamine. Remember that it's not always HCl that gets excreted. This has to happen to maintain the neutrality and the fact that the urine will not be able to tolerate a very high concentration of H+. Now note the three mechanisms. The common thread is that CO2 diffuses freely inside, finally releasing HCO3, and this is the source of the H+ coming out. Now when the sodium goes in and the hydrogen goes out from the sodium hydrogen antiporter system, the hydrogen combines with sodium phosphate to form sodium dihydrogen phosphate. Whereas when it's glutamine, the glutamine breaks up in the PCT cells to form bicarbonate, two molecules, and NH4. This NH4 goes out in exchange with sodium, combines with chloride to form ammonium chloride, which is an acid. So in the end, there is a release of H plus from the body. The next mechanism in the collecting tubules is that the ammonia goes out, the sodium hydrogen antiporter gets H plus out, both of them combine to form NH4, combining with chloride to form ammonium chloride. The same product as with glutamine, but the difference is that the NH3 is from a different source and the H plus is from a different source. So this shows you how hydrogen ions are excreted in the urine along with other small buffer systems. This pump is also necessary to understand, wherein sodium and glucose co-transporter gets sodium and glucose in the cell. The sodium potassium pump works as usual in the plasma. Therefore, glucose is reabsorbed along with sodium. Because the level of sodium increases inside the cell, sodium potassium pump gets active. Now the potassium is driven into the plasma, whereas on the other side you can notice that there is the sodium potassium antiporter system. Now the sodium potassium antiporter system works along with CO2. So there is a net entry of CO2 which becomes bicarbonate, which is released into the plasma. Potassium comes in and this is ultimately exchanged for hydrogen. So this explains how H plus is exchanged for potassium in the cells of the kidney. Acidosis is more common than alkalosis, at least as far as surgery is concerned. Therefore, I am going to emphasize on metabolic acidosis and metabolic alkalosis, because these phenomena in metabolic are more interesting to us. The mnemonic to remember anion gap acidosis is mud piles. And one uses methanol if there is uremia, diabetic ketoacidosis, Paraldehyde, which is I don't think used much these days, infections, sepsis, iron therapy, lactic acidosis, use of ethanol and Salycilates. It is stated that the use of soda bicarb in lactic acidosis and ketoacidosis may not be that beneficial, because the soda bicarb causes metabolic alkalosis in the ECF and interferes with the offloading of oxygen from hemoglobin. Also, the bicarb gets into the cell, combines CO2 and H2O to form carbonic acid, and this raises the PCO2 in the cell, worsening the intracellular acidosis. Metabolic alkalosis is rare unless there is an increased production of bicarbonates or an impaired renal excretion of bicarbonates. Alkalosis is usually accompanied by hypokalemia, as per the pump which we discussed earlier. Now, an interesting phenomenon to see is when one has a prolonged vomiting with a closed pylorus, which occurs in gastric outflow obstruction. When one vomits, he is going to lose acid, chloride and potassium. Therefore, there is going to be a hypokalemic metabolic alkalosis. Initially, in response to the alkalosis, there is going to be a urinary bicarbonate excretion. Now, when this occurs, it is going to actually worsen the alkalosis. Therefore, there is a hydrogen ion reabsorption which is associated with a potassium excretion. Now you will understand that potassium has been excreted by the kidney and also been lost in the vomitus, which is an ongoing phenomenon. When there is a loss of volume, the aldosterone gets kicked in, where there is a retention of sodium and water, and this results in a further loss of potassium because of the sodium potassium pumps that keep working. Thus, there is a resulting hypokalemia which leads to the excretion of hydrogen ions in the face of alkalosis. Thus, there is a paradoxical aciduria, which is the final phase that occurs. So, the metabolic derangement that one sees is hypokalemic, alkalosis, with paradoxical aciduria. The treatment for this basically involves replacement of the volume deficit with isotonic saline and also potassium replacement once adequate urine output is achieved. When one would want to interpret the acid-base gases, you should see the ABG report along with the Chem 7, which takes into account the blood urea nitrogen, creatinine, sodium and potassium and chloride. The first thing that needs to be done is to calculate the anion gap. To do this, take the value of sodium and subtract HCO3 plus chloride. Normally the anion gap is 12 and it is roughly equal to albumin times 3. Now, the anion gap basically tells you the amount of organic proteins that are there which are negatively charged and they are floating around in the plasma. The next thing to calculate is the delta gap, that is anion gap minus 12. Now here the understanding is that if you add an acid to the plasma, for every molecule of acid that you add, one molecule of bicarbonate is used to neutralize it. Therefore, the anion gap should be equal to the delta gap. But if the delta gap increases, this means to say that now there is a metabolic alkalosis, because there are some conjugate bases floating around which are unaccounted for and they have used up the bicarbonate. Thus a dropping bicarbonate level and a raised delta gap represents metabolic acidosis, because in acidosis the bicarbonates dropped as they react with hydrogen ions. Now you add the delta gap to the bicarbonates. If it's more than 24, that means there is metabolic alkalosis. Whereas if it's less than 24, it means there is metabolic acidosis. Next thing to see is the base excess, which ranges from minus 2 to plus 2. If it is a negative value, it means that there is acidosis. Whereas if there is a positive value, it means that there is alkalosis. The next thing to look at is the pH and the PCO2. It's common understanding that if the PCO2 goes up, that means one is retaining PCO2, the person is now in alkalosis. Therefore, pH and PCO2 are in opposite direction, shows that it's a respiratory phenomenon. Likewise, if the person washes away CO2, the pH will immediately fall down. Now, if pH and PCO2 are in the same direction, it means that this is a metabolic phenomenon. So see your pH and your PCO2 to decide whether it's a respiratory or a metabolic phenomenon. The next thing to use is the Winter's formula, which is superimposed on this Davenport graph. Now observe the green line here, which states that the pH is now low, that means it's in acidosis. At the same time the PCO2 is high. So this means we are right now in opposite directions. So this is a respiratory acidosis. Look at the curve when it goes to the right side, where the pH is high and the PCO2 is low. Since it's a very rapidly changing curve, this tells you that this is an acute respiratory acidosis. The blue curve is totally opposite, that the pH is low and so is the PCO2, and on the opposite side the pH is high and even the PCO2 is high. So this is pointing towards a metabolic phenomenon. Obviously towards the left is acidosis since the pH is low, and to the right is alkalosis. Another graph which follows the almost similar curve of the green graph, but here there is a very nice gentle straight curve which comes down. That's because this is a chronic phenomenon, and you know in a chronic phenomenon the kidney starts kicking in, and when it does so you have the same picture of pH coming down when the PCO2 goes up, but the curve is more gentle, pointing out to a chronic phenomenon. Now what you need to do when you use the Winter's formula on the Davenport graph is that in any metabolic process which is on the blue curve, start with the ratio of HCO3 and PCO2, but start with bicarbonate. That means for every 1 point drop of bicarbonate, the PCO2 drops by a point. Whereas in metabolic alkalosis, for every increase in 2 points of HCO3, there is a 1 point increase in PCO2. Now if the values that you have follow the Winter's formula, means that there is good compensation. If it doesn't, it means that there is poor compensation. When you look at the respiratory portion, you need to start the ratio from below, that is with PCO2, because that's the one that's getting affected. So again, the ratio is HCO3 to PCO2. In the case of acidosis, for every rise in PCO2, there is a compensatory rise in HCO3. The difference in the values will tell you whether it's acute or chronic. Likewise, in the alkalosis portion, for every drop in the PCO2, you should check how much of HCO3 gets dropped. This is how you can apply the Winter's formula in the assessment of the ABG. Thanks for watching. Like, comment, subscribe, email me.